Hello, and thank you for joining us for today's hybrid education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Update on Radiotherapy Techniques and Outcomes. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer and by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our programs include support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join a community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter your questions into the chat function found at the bottom of the Zoom window at any time. Without further ado, I introduce our workshop speaker. Dr. Thyra Endicott is a board certified by the American Board of Radiology and currently the alternating medical director of the Radiation Oncology department at Torrance Memorial. She was chair of the TMMC bioethics service for many years and serves on the TMMC Foundation Board and numerous committees, including our own CSC South Bay Professional Advisory Board. Thank you so much for being here with us today, Dr.
Endicott. It's very nice to be here. Can you already hear me? Can you hear? And I just want to make sure that the people at home can hear as well, but I'm sure that our host will inform us. It's all working? Okay, great. Thank you. Thanks for the kind introduction. All right. Well, I met a couple of you already, and I know my old friend Stan from our running club that you've been a member of for maybe 20 years, longer,
30.
maybe 30, and was a great part of my life for a few years before COVID. Anyway, I'm a radiation oncologist at Torrance Memorial, and it's very nice to be able to talk to all of you and to everybody at home about my beloved specialty. It's hard to love radiation, but I do because it can be so helpful. And the ways that we're able to deliver it are becoming so much more precise. Is everybody hearing me? Everybody okay? Here, okay. And hopefully at home. So just to give you a quick overview of what we're going to talk about today, I wanted to explain how radiation works, because it's not just a black box mystery. It's very, very well understood how it works and why, and where we put the dose and why. And then talking about for what cancers it is useful, which is almost everything in different scenarios, how we can use it most effectively and safely to maximize the cure rate and minimize the side effect rate, and how are we advancing the technology? What are the new things that are coming along, and what's our newest technology at Torrance Memorial, with which I'm so familiar. And I also thought we could talk about what are the current cure rates for common cancers towards the end. And then also, if anybody had a specific question, I would love to address it. Let's see. Advancing the slide. It's not doing it the usual way. Just tap. Now it'll work. Okay.
Now it's there.
Okay, great. All right. So first of all, I did want to have some sense of who is here today. I'm not going to question the audience at home, although you could put it in the chat, and maybe you could let me know if anybody has any chat additions to the discussion. But if you feel reasonably comfortable about saying why you're here and your name, if that's good too. You don't have to, but I would love to get a sense of why you came today. Do you feel comfortable sharing that? Or, I mean, obviously this is all very personal to you. If you don't want to say anything, you don't have to. But
fine. I'm here today because I've already had radiation therapy at Torrance Memorial.
Okay. Right. And how long ago was that?
Was in December.
Oh, so quite recent. Quite recent. And I'm glad to see you enjoying a good meal and being out and about. So that's encouraging to me. I hope you're feeling reasonably well.
Yes, I am.
Good. And then how about other people at your table?
I'm David.
Mhm.
I have prostate cancer and lymph nodes in the pelvic area and considering radiation soon or, in the future.
Right, okay. Well, I'll talk a little bit about radiation for prostate cancer specifically. And you're the wife, okay, you're the partner. And how about you?
Hi, I'm Michael. I was successfully treated with radiation therapy at Torrance Memorial about 3 years ago. Dr. Mahmood is,
Dr. Mahmood.
yeah, he's fantastic.
Oh, good. I'm so glad to hear that. Yes, that's great. And you're looking well and fit. And
Yeah.
makes me happy. Good, good. And behind you, the table behind.
I'm Elna. I'm a breast cancer survivor,
Mhm.
recently treated in August and September with radiation therapy at Orange Coast Memorial.
Oh, okay. All right. Oh, welcome,
So
welcome.
I'm here to find out a little bit about
What happened? Right. Good. Yes. Sometimes there's not time. The sort of the stream is going so quickly that you're in the midst of it and you don't have as much time to think about what you're doing and why. It's nice to have some retrospect.
Stan,
Mhm.
I did have prostate cancer back in 2003 and I chose surgery at the time.
Uh-huh.
My wife had breast cancer about 5 years ago, and after a lumpectomy, she also had radiation.
Uh-huh. Okay.
And I've had some imaging done which shows, strange things in my body. So I'm interested in knowing how it might be treated in the future.
Okay. Anyone else feel comfortable? Yes?
Yeah, sure. My name's Mike, 29-year survivor with non-Hodgkin lymphoma.
Excellent.
And recent image shows a 5-centimeter growth in my hip area.
Uh-huh.
And it's the only place I've been in remission for 3 years and now I've come back a little bit.
Uh-huh.
So I'm considering radiation. I've had radiation 3 times before over the last 30 years.
Right?
So if the method of delivery has changed,
Mhm.
I'm gonna bring it up in consultation on this Thursday
Okay.
about an option to use radiation instead of a magic mixture.
More chemo or immunotherapy or targeted therapy. And so many things that can be done for lymphoma. Radiation is usually very effective. I hope that it was useful to you in the past.
But it's a chronic situation that
Yes.
I have, and each time it's been here, it's been there. And each time it's put it into remission for 3 to 5 years.
Except in that one spot. That's encouraging.
Yeah.
Yeah.
Hi, my name's Chris.
Claire?
And, I'm here basically for education. I was diagnosed with breast cancer, DCIS stage 0, and I'm in a clinical trial right now in November 22. So I'm just on very close watch with 6-month mammograms. And
Mhm.
so I have a sister that went through radiation for a tumor at the base of her neck, and anyway.
And I hope she
Never
did
know
okay.
what's gonna happen. She is.
Okay.
She is.
Good, good. Great. And Maria?
Yeah,
Uh-huh.
yes, and I have radiation treatment with 24. Was a very successful treatment, and I'm here to learn more about that.
Right. And then lastly, our last in-person guest. Paul?
Yes, I'm also here to learn as much as I can about radiation.
Mhm.
The word radiation personally scared, what out of me. So now we're just trying to be objective and try to see what it's all about.
Okay. And are there any chat comments? Well, no, that's all right. We'll move on because we've got a lot to cover and not that much time. I wanted to just give you sort of a broad overview of why we use radiation therapy. The best case scenario is we use it to cure cancer. We destroy the tumor cells and do our best to spare all of the normal cells. Obviously, that's not quite possible, but we spare them much more than we concentrate on the tumor, we spare the normal cells by keeping the fields really, really tight, and by choosing doses that are quite likely to harm the tumor cells and quite unlikely to harm the normal cells. So say for radiation in the head and neck, where you really can't avoid a lot of normal tissue. You do everything you can to shape the radiation tightly on where you know the cancer is or could be, and spare everything else, the voice box and the parotid glands, to try and keep those tissues as healthy as possible. I think of them as precious tissue. The normal is precious and the tumor cells need to be obliterated. So trying to make that happen is the whole point of what we do. So we destroy tumors locally that have not spread to other parts. That's one of the main roles of radiation. Sometimes we do the radiation after chemo or after surgery, where it looks like the tumor might be completely gone, but if you follow along for 6 months or a year, it's quite likely to recur. And adding radiation therapy as sort of a secondary or adjunct treatment in that scenario can reduce the risk of local recurrence and improve survival. So sometimes we use it for tumor we know is there, and sometimes we're the mop-up crew. Sometimes we're the pre-treatment. We like sort of when you're doing the laundry and you put stain remover on the spot. Sometimes we do radiation ahead of surgery or ahead of chemo to reduce the volume or the number of cancer cells before they have surgery. And then it can make the surgery less invasive, less extensive. And then also, I know we always like to concentrate on cure. That's what everybody wants, is cure. But when we know that we can't achieve that, we also can use radiation therapy very effectively as palliative treatment. So which means to improve symptoms, to improve the quality of life. Sometimes that also improves the length of life. But in the setting where we know we can't cure, the main goal is to improve the quality of life, not necessarily the length of somebody's life. So we can alleviate pain or neurologic symptoms. If somebody has a tumor in the brain, for example, we can stop bleeding. We can open up an airway so that somebody's breathing is better. Lots of different ways to use it. So the best treatment plan for any one individual is very individual, and it's usually determined by a group of physicians. We have several different tumor boards at Torrance Memorial, and they do that at Little Company and at Long Beach as well. We're a panel of experts, radiation oncologists, pathologists, radiologists, medical oncologists, surgeon would all meet together to talk about all the breast cancer patients that are newly diagnosed, all the lung cancer patients, prostate patients, head and neck patients. So we have, between Torrance Memorial and then the groups that we participate in through our connection with Cedars-Sinai, we kind of cover all of those bases so that not necessarily every patient with a new diagnosis of cancer, but the tricky ones are all reviewed in a multidisciplinary way so that we can feel we're giving them the best chance for everybody to think about different perspectives and what's the best combination of treatment to cure that patient and maintain optimal function. Sometimes, again, we decide radiation is the only treatment needed, and sometimes it's the combination. Then there's different types of radiation therapy. Almost every patient who has radiation across the world has an external beam high energy X-ray. It's really just a high energy X-ray. I think sometimes that helps people understand. It's like coming in for a CAT scan, but the CAT scan will kill your cancer. So it's a high energy X-ray generated by an electrical current. So when the machine is off, there is no radiation. Sometimes patients are worried they're going to be radioactive when they go home, but it's very uncommon for that actually to be the case. Only with like radioactive treatment for thyroid cancer, where you actually ingest the radioactivity. That is something where you have to be careful and cognizant of risk to others for a few days. But almost all radiation therapy is delivered instead by a high energy X-ray generated by an electric current. We love to shape the radiation very carefully, as I've talked about, and I'll show you some examples of how we can do that. And one way to do it is what we call three-dimensional conformal therapy, where you keep the beam sort of open on that target, but treat from a number of different angles. Much more commonly these days, we do an arc therapy where this high energy X-ray, and I think you had this, the high energy X-ray rotates around you. And as we are rotating the beam around, the shielding is in constant motion. I'm going to show you a little video, the animation of that. So that's called intensity modulated radiation, where the shielding is dynamic while we deliver the treatment. There's also proton beam therapy, which is extremely expensive modality that's only available in a few places across the United States. Loma Linda, UC San Diego has it. It's a particle beam. So some of you probably know what a proton is versus a photon. A photon is a high energy X-ray, or well, in our case, a high energy X-ray. A proton is a tiny particle with a positive charge. It gets absorbed in a very particular way as it impinges on tissue and can be really useful for treating small lesions close to a really critical structure, like a melanoma of the retina, say, that's close to the optic nerve. That's a sort of a perfect scenario for a proton beam treatment. Very few centers across the states have it, and almost all treatment is delivered instead with a photon beam, PHOTON. And then the last modality here is something that we use more and more commonly, stereotactic body radiotherapy or radiosurgery. All that means is highly conformal radiation therapy to a very small target with maximal imaging and perfect localization over very few treatments. So we use this for brain metastases. Say somebody has a lung cancer that has spread to the brain and they're otherwise doing well, but we need to obliterate, say, a 1 centimeter, a half-inch lesion in the left frontal lobe. We can deliver radiation to that lesion with a 1 millimeter margin extremely precisely, give one dose and that lesion will be gone. So it's a beautiful technology. It's everything sort of piled on to one special treatment. And for that, it's such sort of an intense labor of love that the physicist is there. I'm there throughout the whole course of treatment. The radiation therapists are there. Often there's very special immobilization devices and some sedation for that. So it's more challenging, also highly effective at obliterating tumors, because you can give a really high dose when you know you're in exactly the right place and everybody's watching so carefully. So it's one of the more fun things that I do because it is just so effective and the risk of side effect is really very low. And then lastly, there's internal radiation therapy. Some people have implanted radioactive seeds in the prostate for prostate cancer. That's probably the most common way that that is used. And for some gynecologic cancers as well, not seeds, but tiny little radioactive applicators with high dose iridium is used to keep the radiation, to keep the cancer from growing back at the top of the vagina or in the uterus or cervix for cervical cancer. Just to reiterate that the radiation we use is an high energy X-ray. It's on this very well-known electromagnetic spectrum. It includes visible light, it includes microwaves, gamma rays, all on the same spectrum, radio waves. So we're just exploiting this very naturally occurring phenomenon. And the way that it works is that the DNA, the supercoiled helical molecule that holds the genetic code of our being in every cell, is the most vulnerable to radiation because it's such a complex molecule. As you can see that in the picture here, that there are these side coils. My cursor isn't working, that's too bad. But there's side coils and then there are these cross-bridging atoms that bind together to keep that supercoiled DNA. And the radiation, as it impinges on the patient, releases high velocity electrons. So even though it's a photon beam, a high energy X-ray, but once it hits the tissue, it generates tiny, inconceivably tiny little bowling balls of these electrons that have negative charge, tiny mass, and they will break up the DNA, which sounds like disastrous, right? You're bombarding my DNA with radiation, with electrons. That doesn't sound good. But the reason we get away with this is that the normal cells are so much better at repairing DNA changes than the cancer cells are. So our normal cells stay normal because we repair our DNA all the time. Cancer cells are cancer cells because they've forgotten how to repair their DNA. So we exploit that weakness. And then where does the cancer go? As the DNA is damaged, the cancer cells die, not necessarily immediately, but often when they move into a dividing phase of their life cycle, and they get trapped in that division phase, and they can't function and they die. And then your immune system clears them away. So somebody who has a lymphoma in the hip or in a node of the neck, for example, lymphoma tends to resolve quite quickly, but sometimes it can take days or weeks to see that lesion being slowly whittled away by your immune system as it clears away the dead cells. Let's see, here's a sample of a linear accelerator. This is the kind of machine that we have at Torrance. All of our patients are treated on this TrueBeam technology. And at Little Company as well, they have TrueBeam, and at Long Beach. It's not that this company has a monopoly, they just have a really, really good machine. And they have excellent service. So we love it when a patient gets through 6 or 7 weeks of radiation without any interruption in their treatment, because our uptime is so good. And I hope you experience that.
One down day.
One down day, that's right. We have the sort of premium service contract that our Julius, our radiation technician, is there within usually about a half hour if things aren't working, because it's very stressful on patients and on us when the machine isn't working. We just have to keep it up. So this machine works beautifully. The imaging is fantastic. The delivery is rapid. It's called rapid arc, the arcing kind of treatment. And we can get the patient on the table, imaged, treated, and on their way, often within about 10 minutes. This is an example, a little video of how we position a patient for treating a brain metastasis. So you get a sense of there's the couch. We call it a robot because it can sort of present the patient for the beam and modulate in incredibly fine increments so that we can line the patient up exactly as we had planned their treatment. And then we have this beautiful computer augmented AI way to process the imaging extremely rapidly and precisely so that we can do it on the fly. So there's x-rays being taken, the couch gets shifted into the right position, and then the beam is going to come on. And the treatment beam here is that red beam coming out of the head of the machine. And then you can see, even while we're treating, we can take these exactly 90-degree angled x-rays out of the floor to make sure that with each different angle we're treating this patient, the setup is perfect. We can treat a 2-millimeter brain metastasis and we know it's going to be gone. So a machine this big, a meter away from the patient, the accuracy of the beam is less than 0.5 millimeters variability. That's how confident we can be. So then this is an example of a patient we treated on this machine with exactly this technique. You can see it's the brain, and you can see there's a sort of a pink lobular sort of little ball at the top. That's the tumor target. And then the green and red balls are the eyes, and then the brain stem down at the bottom. We really like to avoid the optic system when we're doing radiation treatment. So that's why we particularly highlight those areas. And then you can see this sort of slash stripes of color at different angles across the top of the head. So those are the different beam angles that the radiation is coming in across the brain. So we're spreading out a low dose and concentrating the high dose by coming in at all these different angles, always focused on the tumor. Does that make sense? Okay, good, good. And then this is the sort of dose distribution you'll see here. This is a slice in this direction, showing the white part in the center. You can see through the pink. That's the known tumor, and we give a little expansion volume for cells that might be creeping out of what we can actually see on the MRI. And then you can see that those dose lines beyond it drop off very, very quickly. So the dose to the rest of the brain is like 3% of the dose that's within that pink sphere. Okay, so the dose drop off is very, very rapid, and the chance of causing damage to the normal brain is close to 0. This is an example of a woman who had 2 brain metastases treated here. You'll see, actually, there were 3 of them. There's one, I'm sorry I can't show people at home because my cursor isn't working, but I'm showing people in the room. There's this front lesion, then a second lesion here, and then you can see there's this tiny lesion in what we call the cerebellum. So it's down here. So 2 up top close together, and then a 3rd one below. And you can see over the course of between September and March of that year, the tiniest lesion in the cerebellum just disappeared. The other 2 lesions gradually involuted, got smaller and smaller. Okay, here's an example of a person with a lung cancer being treated with this ARC treatment. The yellow sort of train track half circle that you're seeing, that symbolizes the arc of the radiation coming around that side of their body. And the colored lines in the bottom sort of left of the image. This is in the chest area. You can see the vertebral body here. So that's the backbone, spinal cord here. Black is the air in the lungs. This is the heart. This is the stomach. This is the tumor. So we were able to treat that with maximal sparing of the normal lung. Often patients who have lung cancer already have significant compromise of their lung function. So we really work very hard to spare the normal lung as much as possible, keep that dose as tightly as we can to where we know there's a tumor, with enough wiggle room for movement and uncertainty about how the patient will be breathing that day and where the tumor cells might have crept out of what is obviously tumor. And then here's just a 3-dimensional display of this same idea. Here's the tumor nestled down in this back part of the lung. And then this is a front view, and this is a side view. And it looks like this dose cloud is bigger than the tumor. Do you see that? See the tumor here, and then this dose cloud is bigger. That's because the patient's breathing while we treat them. The treatment takes about 4 to 5 minutes. We can't have them hold their breath for that amount of time. So what we do instead is we do a movie of them breathing, and I'm going to show that to you. We do a movie. We can actually watch people breathe. I think it's just amazing. Patients sort of like to see themselves breathe too. I bring them around to see this video, and so what we do is we expand the radiation field to cover this movement so that the tumor's not moving in and out of the radiation field. Just another couple of examples, a tiny lung cancer in the towards the back again near the vertebral body, and then here's a tiny lung cancer high up at the top of the lung. This is the video that I told you I was going to show you that shows how the shielding in the head of the machine moves while we're radiating. So the radiation is arcing around this patient. The red is the tumor, and then I think you get a sense of their rib cage. And we're seeing sort of the beam's eye as it rotates around the patient, and I'll show you again while I'm chatting. So you see when the beam has a really good eye on the tumor and there's not much really critical normal tissue between the beam and the tumor, the leaves are mostly open. But when we're coming through something critical like the spinal cord or the heart or the esophagus, the leaves will be mostly closed. So it's called intensity modulated radiation. Did anyone have a question? No. Okay. Yeah.
Could you repeat your last statement?
Right. When the beam is seeing the tumor without any critical tissue in between the head of the machine and that tumor, those shields will be mostly open. But when the beam, so maybe when the beam is coming through the direct back, right where the spinal cord is, those shields will be almost all closed. So it differentially shields different critical tissues.
Because one of the questions I was is that when the beam is traveling through the body, what are the chances that it will do damage to other tissues that it's going through? Because if this is a high energy beam, I heard you say something about the normal cell can repair itself. But then again, I'm just curious in terms of if it's gonna kill the bad cell, wouldn't it have also some kind of effect on the good cell when it's going through that organ?
Yes, we're thinking about that all the time. And okay, oh sure, of course. One of our in-person attendees is asking about how we manage to spare the normal tissue while we're killing the tumor cells. So we do it we use every tool we can think of to spare the normal tissue. So one way is to keep the dose as low as we can. Another way is to keep the shielding as tight as we can. Another way is to make the imaging extremely precise so that we can say within 0.5 millimeters that we're in exactly the right place. So we keep the fields tiny when we can. And we also, one of the main reasons that we fractionate radiation, we split it up over several weeks for larger radiation fields, is that gives the normal tissue time to repair while the tumor cells continue to accrue more damage. So one of the main tools we have to help normal tissue heal is to split it up over time. Is that sufficient? Okay.
It's just one of those things you don't have absolute, but do the best you can.
Yeah, exactly. We cannot say that we will not cause side effects, but we can say the risk of a severe side effect will be in the range of, depending on the situation, 1 to 5%, kind of thing. And of course, I treat 300 to 400 patients a year, probably myself, with radiation. I'm going to cause some of those side effects. I know it. And it's the hardest part of my job is the side effects. I mean, curing cancer is wonderful. Dealing with the side effects is the hard part. So we do everything we can up front to have excellent imaging, excellent technology, know where the tumor is, know where the risk is, treat as little as possible, but we also don't want to underdo it. So it's always a fine balance. Just some advances in radiation therapy for breast cancer. I chose that one just because it's such a common treatment site. One of the things that we've been doing lately is, well, I would say the last 15 years, we adopted this very, very quickly. I'm Canadian, as you might hear from my accent. And a Canadian group studied whether or not we could move from treating with what used to be the old standard of 25 or 30 treatments for breast cancer to the whole breast. If we could reduce that to 15 treatments, treat a higher dose per day, and still have excellent cosmetic outcomes and very good tumor control. So that was a randomized trial done over 15 years, those patients are still being followed. And it was a perfect study. It turned out that not only was the cure rate as good, but the cosmetic outcome was a little bit better. So that's exactly the sort of thing you're hoping for. It's easier on the patient, faster, less expensive. And the cosmetic outcome was better. So that we adopted that now 15 years ago. Now, because it was such a success, the same was done for prostate cancer. In the old days, it was 8 weeks of radiation therapy. These days, our standard treatment when we're treating a larger prostate or including the adjacent tissue or the lymph nodes, then now the standard treatment is about 5.5 weeks. But for really early prostate cancer, where there's excellent evidence that it hasn't spread outside of the prostate, in some circumstances, we can treat in five treatments with the stereotactic radiosurgery technique, where all hands on deck, we're all concentrating so hard on making that treatment exact and doing it very quickly. So for breast, and then it's spread to other disease sites too, we treat fewer and fewer courses when it makes sense. And then partial breast radiation is also a new development over the last 10 years or so, where for women with really low risk features, rather than treating the whole breast, you can treat usually about a quarter or a third of the breast with just as good long-term local control and better cosmetic outcome. So you're treating less of them. And when you treat less of the breast, you also treat less of the rib cage, the bone marrow, the heart, and the lungs. So another way we're progressing at trying to minimize the adverse effects of radiation. And then sort of the ultimate in minimizing the risk of radiation is not giving radiation at all. So there are trials being done all the time to look at people with the, trying to define people with the lowest possible risk group who do not need radiation, or where the benefit of radiation is small enough that it's a reasonable choice not to do it. So for women over 65 or 70 with very early breast cancer, that's responsive to estrogen. So we have a pill that can damp it down. We discuss surveillance rather than radiation. And 10-year follow-up on these trials where women didn't have radiation, the risk of recurrence is about 10% if you omit radiation, about 1% if you give it. So radiation still works. It's just that when you're only helping 1 in 10 women, it's worth the discussion about whether it's worth it to that particular woman. So that patient makes her own decision, hopefully with good information. But of course, we also love to treat breast cancer because radiation therapy is incredibly effective for breast cancer, especially estrogen receptor positive breast cancer. Those cells are exquisitely sensitive to radiation. So when it is indicated, I love to treat breast cancer because it works. It reduces the local recurrence rate by 2/3. So for a woman who's 40, who has a 5-centimeter lesion and a node positive, oh my gosh, do I ever want to treat her? Because we will increase her overall survival rate, help her keep her breast, and she usually tolerates it really beautifully. Okay, so we talked about covering the nodes, whether or not to give the node treatment, what circumstances predict for a high risk of nodal recurrence, when do we include them or not. That's often when we're talking at tumor board for breast cancer patients, we go through all of these issues. And then also recently it's become more evident that even for cancers that have spread outside of the original site for breast cancer, even more for prostate cancer, for rectal cancer, other GI cancers, for lung cancers that have spread in just to a couple of places elsewhere, using stereotactic radiation to those other sites can obliterate the cancer. And sort of in partnership with systemic treatment like immunotherapy or targeted therapy, sometimes we see 15 and 20-year long-term freedom from disease, even from metastatic cancers. So I have a patient who is now 14 years out, and she had about 20 brain metastases. She had tumor growing out of her lung through her breastbone, eroding the skin. And we gave her radiation, chemotherapy, and immunotherapy, and she is completely free of disease. And she's been off any treatment for about 4 years, doing wonderfully. Now, obviously, that is an unusual situation, but I want us to recognize that it's possible. So I don't want to oversell that possibility, because it does not happen for everybody. But it's happening for more patients because we have more and more tools available. And the combination of surgery and chemo and immune therapy and radiation, we're getting better at this. Let's see. All right, for breast cancer, we really like to avoid the heart. The breast lies right over the heart on the left side. So we just are very good now at keeping the heart shielded during the radiation therapy. So we use what we call a deep inspiration breath hold. We monitor it with this gorgeous technology where we project an array of patterned light onto the patient. And we also watch them with thermodynamic monitoring and paired with low-dose X-rays. And I'll show you a few pictures of that. But you have the patient trained to take a deep breath into a particular deep breath level that is quite reproducible. And so every day when she comes for treatment, you set her up and you teach her how to do this breath hold, and you can avoid the heart really beautifully. In almost every case of breast cancer now, the dose to the heart is 10% of what it used to be along the front aspect of the heart. So this is one example of that. I should get a picture of a better one, because it's often better than this, but you'll see that the coronary artery is right here, right at the edge of this beam that we're using to treat this breast. And with this, having her take a deep inspiration, it moves just about 1 centimeter or 2 back, and the dose is suddenly 10% of what it used to be. So it's very effective and is a very simple concept. These slides just show that the addition of the pairing of lumpectomy and radiation is actually more effective than mastectomy when lumpectomy is possible. It's not possible for every woman, but I think some women feel like when they choose to have lumpectomy and radiation, they're sort of choosing lesser treatment, but it's actually you're choosing potentially more effective treatment. Advances in radiation therapy for prostate cancer. We already talked about the shorter courses that we're using. Our standard at Torrance Memorial for larger fields is 28 treatments now, rather than the old 38 or 40, or the ultra short course of just 5 treatments with stereotactic body radiation. We used to sort of give up on patients where we knew that the disease had spread to the nodes. We no longer do that, because the technology is better for targeting the nodes and sparing the bowel that sits in between lymph node tissue and the prostate. And we have really good evidence that the cure rate is much better if you do offer radiation therapy in the setting of node positive prostate cancer. We used to not do it until we had better information. So now that's a huge step forward. And then also prostate cancer is one of the specific scenarios where even a person who has metastatic disease, as long as it's low volume and very few of them, adding radiation therapy to those metastasis sites increases survival. Let's see, the Calypso tracking system is something that we have at Torrance that's a little bit too complex to tell you quickly, but I'm going to skip that one. I'm going to show you an example of SpaceOR, which is this hydrogel that we now often will have the radiologist put in between the rectum and the prostate gland to give a little extra wiggle room. And I'll show you a picture of what that looks like, so that the high dose radiation, instead of being on the rectum, because it's right in front of right behind the prostate, the dose will now fall into this hydrogel where it has no impact on rectal function. So we've reduced the risk of rectal problems after prostate radiation into the range of about 3%, where you'd have bleeding or ulceration, pain. So that's a really, really sweet idea that's panning out for us. And then also there are many men with early prostate cancer that will never shorten their life or reduce their quality of life. So we want to identify those men and not radiate them or not do surgery for them. So that's a huge area of development too. Who's the most appropriate person not to have radiation or surgery? And there are very clear criteria for that now. This is this hydrogel that I talked about. You can see this is an MRI, so it's a little bit fuzzy, but the prostate is labeled here. And then the rectum, it normally is right behind it, prostate rectum. So the back of the prostate is the front of the rectum. So if you can imagine superimposing radiation field here, you're treating the front of the rectum with the high dose. In this setting though, you treat the prostate and the high dose ends in this hydrogel. So it's just an elegant, effective way to spare rectum. These are just pictures of this brain exact track dynamic system that I was telling you about that we use for, especially for women where we're treating breast cancer, where we want them to hold their breath. We pair this visual light array that we reflect off of their chest. Also thermodynamic monitoring, so that's the second colorful one, that's tracking the heat emitted by the body. And then also low dose x-rays, so we can identify how the ribs should look on the x-ray and make sure that's perfect. And then here's the whole package put together. You see, this is again, the true beam radiation delivery system. It's a linear accelerator that creates this high energy x-ray, this robotic couch that presents the patient for the beam and can be modulated in 0.5 millimeter increments or less. The x-rays that come out of the floor at exactly 90 degrees. And then the camera up here is what generates the thermodynamic monitoring and the reflected light array. So here's this, it's called high-speed surface tracking. It's just with reflected light. That's what it looks like on the patient. It's beautiful. So this is a pattern that is immediately interpreted and constantly interpreted. So if the patient moves, the machine shuts off because that reflection will be wrong. Okay. Here's the thermodynamic monitoring. Again, if this does not match the expected pattern, the machine will shut off. So if she coughs, twists, the machine stops. And then the low dose x-rays that come out of the floor that we talked about. So yes.
Wanted to know, are all the patients laying down like that, or do they have
different positions? Yeah, most patients are treated on their backs just because it's very stable and comfortable. Sometimes we treat patients prone, lying on their belly. That's quite a common position for somebody who has a skin cancer at the top of their head. We'll lie them prone so we can get a really good look and bring the beam exactly to match the shape of their skull. Yeah, we do that quite commonly. The larger ones, the small ones usually get nipped off quite effectively by a dermatologist or a plastic surgeon. Yeah, but we see the gnarlier ones, the ones that are where surgery would be possibly disfiguring or interfere with function, lose part of the nose, lose part of the ear, that kind of thing. So we often treat. Are we almost done?
Eve, did you have a question?
Yeah, so is the woman lying on her back, is this for breast cancer or no?
We treat, at Torrance Memorial, we treat breast cancer patients lying on their back. There are some centers that treat prone. Was that where your question was heading?
Well, I was wondering, like, in the image before that, where you had all the beams coming down the different colored beams, that, is that, would that be a treatment for breast cancer?
Yeah, well, this is the monitoring for breast cancer. Yes, yes. This woman is being set up for breast cancer treatment.
Okay, but those aren't the X-ray beams that are coming down on her, are they?
No, this is the reflected light. Reflected light, so it has no harmful effect on the patient.
Okay, yeah, it just looked like, she was being X-rayed from her face, down to her.
Down to, no, that's just the reflected light pattern. And
okay.
we usually limit that reflected light to a much more focal area. This picture is just from the company. It looks beautiful. With and then this thermodynamic monitoring too. You don't want to interpret too much of the patient, because humans are mobile creatures and they doze off or they shift a little bit. So you really want to keep the sort of area that you're monitoring as tight as you can. Does that answer your question?
Yes, thank you.
And she also has clothes on? Is that?
Well, that's just for the public consumption, but no, we do expose the skin. It has to be exposed more so than we used to. We used to always cover up one breast when we were treating breast cancer patients, just for the patients to maximize their comfort so they don't feel so exposed. But with this system, you have to be able to have a good view. But they're alone in the room almost all the time, and patients are so brave, so willing just to get on that table and let us get rid of their cancer, that they're willing to expose a little bit more of their chest to have this really wonderful technology work for them. Yeah.
I have CLL. I have lymph node.
Right. Yes, I've seen this scenario many times.
Yeah.
It's
So is radiation be used to get rid of those lymph nodes?
radiation would work for it almost certainly, but we wouldn't impact your survival. We would cause you possible side effects. So with CLL, we almost never use radiation. There are some targeted therapies available now, like light chemotherapy or targeted agents that work everywhere, and can be given when you become symptomatic. But there's been no evidence that doing radiation therapy to broad fields for CLL improves survival or quality of life. So we don't do it unless it's causing pain or interfering with your airway, or becoming sort of disfiguring and uncomfortable, or interfering with range of motion. We do it in that case, and really low doses of radiation are very effective. But in the long run, we don't make enough of a difference. And you need your bone marrow. The more of you that we radiate, the less bone marrow function and reserve you would have. So it's just not a good scenario for radiation as a tool. Okay.
What is CLL?
It's a chronic lymphocytic leukemia or lymphoma. It tends to take a long time to cause trouble. I think depending on the particular subtype of CLL, the average survival rate is in 15-year range, and some patients do much better than that. So it is a chronic condition. It doesn't behave like most cancers. It's very slow growing, and you can do well for many years without treatment. Okay, let's see. Oh, this is one of the things I love to do. This is called stereotactic radiosurgery for spinal metastases. It just sort of brings all of our best tools together. So this is an MRI image of a vertebral body that's pretty well replaced by tumor. So you can sort of see this modeled appearance. I know you don't know what a vertebral body usually looks like on MRI, but it's this modeled change that we're concerned about. And her tumor extended in a sort of a wrap around the central canal where the spinal forward and the spinal nerves traverse. So we really want to be able to give a high dose of radiation to this tumor and keep the radiation dose to that central white canal where the critical nerves run. Want to keep that dose as low as possible. And when we pair this rapid arc technique with this modulation of the radiation as it arcs around, and then we pair it also with that technology that I showed you, this ability to monitor the X-rays rapidly and incredibly precisely, also keeping that monitoring of the patient's breathing movements, bodily movements, constantly monitored. When you pair that all together, you can deliver radiation doses like this where we can wrap the beam around a very critical organ and be confident that we're sparing that critical organ. So yes. 4 minutes, okay. Anyone have any questions about this? My favorite modality. It's so effective too. This woman had very severe pain from that metastasis in her backbone, and her pain was alleviated very quickly. Not completely yet. This is actually quite recently that I treated this, but it was a wonderful response, and she had essentially no side effects so far.
I have a question about tumor shrinkage.
Mm-hmm.
So what do you, if you, let's say you've shrunk a tumor, then how do you do surveillance?
It varies so much depending on the site. So for breast cancer, which is the most common, hopefully there's nothing to survey, that the tumor's been removed with surgery, and then any cells that might have lingered behind in the breast have been taken care of with radiation, and cells that might have traveled have been taken care of with anti-estrogen treatment. So we aren't really watching the tumor. We're watching for recurrence in that scenario. So we still do mammograms, possibly MRI of the breast, possibly ultrasound. For prostate cancer, another really common one, we don't so much monitor imaging, we follow the PSA, it's a blood test. And that is highly predictive of tumor control. So that's a nice and easy one. For head and neck cancers, we will get a new baseline image, whatever showed the tumor best before we treated. So an MRI or a CAT scan or a PET scan. We get that up front, and then we get a new baseline, and then how often to repeat it is debatable. And there are different schools of thought about whether you really keep a close eye on it or you actually monitor more clinically. So it varies so much from one disease site to the next. Did you have a particular site in mind?
No, I was just wondering when you show the breast cancer tumors, yeah.
Okay. Any other questions?
Yeah.
How does frequent CT scan exposure, X-rays causes cancer?
Yes, that is true. Any X-ray chronically given can cause cancer. So you only want to give radiation when the chance of helping that person far outweighs the chance of that tiny risk. So when we're treating somebody with a diagnosed breast cancer, where we know that we're going to reduce their local recurrence by 2/3 and add to their overall survival with all the other modalities of treatment they'll have, it's so worth doing the radiation. And it's so worth doing a mammogram to follow that person up. The risk from lots of X-rays, mammograms, CAT scans is really a population-wide risk. You have to look at hundreds of thousands of people to see meaningful differences in risk of cancer. So it's become more and more common practice for everybody to think about, stop and think before they order any test, and always do the risk-benefit analysis of whether this really serves the patient well. But it's certainly true, if you do a million CAT scans, you're going to cause a couple of cancers.
just have a question in the chat.
Sure.
So after breast cancer radiation, how long does the breast continue, how long does it take how long does the breast continue to shrink?
And that's highly variable, highly variable. Yeah, and let's see, sometimes the seroma, the sort of the fluid left behind after the surgery, that generally resorbs over the course of a few months after radiation. So sometimes the shrinkage is actually that the patient's healing from the surgery. But the radiation also can cause up to about 10% shrinkage of the breast tissue. And it's in a sort of a more diffuse kind of way that the breast gets a little bit smaller on itself. It's so variable from one person to the next. I would say for my patients, about 80%, it's not a significant issue. 20% of them will notice that this is different. And about 5%, it'll be significantly smaller. And it'll make that patient sad in the long run. Sometimes, and over how long might that last? I see that probably over the course of a year or two, and then it sort of settles down. I have been in practice long enough now that I've seen many of my patients that I treated 25 years ago come with something new. And generally, I'm quite relieved at how well they tolerated breast surgery and radiation in the long run. But every little while, there'll be an outcome that I am sad about, and the patient even more so. Does that answer your question? Okay. I don't think there's more. Oh, right. Oh, yes, there are. There's 3 more. Just sort of update on cure rates for prostate, breast, and lung, just because they're so common. So these days, 5-year survival rates after a diagnosis of prostate cancer, localized or even regional, where it's extended beyond the prostate gland, the 5-year survival rates are practically 100% because there's so many wonderful treatments available. For somebody who presents with disease that's spread to the bone, for example, which is so common for prostate cancer, it's the #1 site for metastasis, that risk drops off very, very quickly, which is why you try to find patients with prostate cancer at an early stage. You want them in those top 2 categories, not in the distant category. There's a lot of controversy over whether to do PSA screening. I think my approach, and certainly what I've asked my husband to do, is have the PSA monitored every year or 2, and then have a good discussion with your primary doctor over whether an uptick is meaningful and whether it needs to be investigated further. So it's a useful tool, but it's not a perfect screening tool. But we do like to find prostate cancer early. Breast cancer survival rates are actually quite similar. 5-year survival rate for localized just to the breast itself. Almost 100% of women with early stage breast cancer, no matter what their markers are, we expect to do well for a long time. Especially, and unfortunately, there are subgroups where that is where they're at higher risk of the disease coming back, and then they will get more intensive treatment. Even for women where it's spread to the nodes, the 5-year survival rate is close to 90%. And I have many patients who had multiple nodes positive at diagnosis who are long-term survivors, no evidence of cancer. But also breast cancer too, once it's spread outside of the breast and the immediate nodes, it's a more difficult problem, and the survival rate drops off very quickly. Mammographic screening is the best tool we have. I know it's terrible, it's awful, I hate having them, but it does work. It's the best tool that we have. And physical exam, and having a primary doctor that you trust and see regularly. And then for non-small cell lung cancer, localized lung cancer, where it's stage 1 or 2, 65% 5-year survival, which doesn't sound that wonderful, but it's so much better than if it's spread to lymph nodes or more distantly. So CAT scan screening for patients with higher risk of lung cancer, smokers, current smokers, or people who have smoked within the last 15 years. Talk to your primary doctor and get your lung cancer screening. Oh, and then here's our beautiful department. So I'm very proud of our equipment, obviously, but the most critical component by far is the teamwork. People paying attention and working well together, being excited about developing these tools. Okay, I will stop there.
Thank you so much, Dr. Endicott. We're about 5 minutes over. Did you want to take more questions or?
Well, I'm happy to.
Okay, so if there's any questions online, please feel free to put into the chat or unmute yourself. And if there's any questions in person, yes, go ahead.
So the gentleman asked before, the beam of treatment to the target. There's good tissue in between.
Yes.
So the image is a little behooving. I've had radiation before, so I know that. But this cup is my target, and this is the path of the beam, right? There's good tissue behind the target.
Right.
Protect that. Because the beam is going through the target. It's not completely absorbed by the target, right?
Yes, yes. The doses are calculated in a 3-dimensional array. So we know exactly what dose is beyond and before the target. So let me go back to that. This one. This includes the entrance beam and the exit beam. Any dose is represented in this picture. This is the high dose region, obviously. I didn't show the lower dose sort of spread of radiation, but yes, we know that the beam doesn't just stop at the tumor. There is some exit, but the dose is attenuated by normal tissue too. So the energy is dissipating as it passes through. So the exit dose is actually a lot lower than the entrance dose, but it's all taken into consideration. The software we have is incredibly accurate, saying exactly pixel by pixel within this matrix, what tissue is getting what
You
dose.
mentioned before that when there's a vital tissue in the path, the aperture mostly closed.
Right,
So
right.
that would,
yes, but I was just that sort of shorthand. But yes, if there's vital tissue in the exit path too, we take that into consideration.
right, that's all.
Yeah, yes. Yes.
I noticed there was a cage around.
A mask. We call it a mask, not a cage. Mask sounds better.
That serve? Is it protective?
No, it's to make sure they don't move at all. At all.
You can repeat the question for those.
Oh, yes, sorry, yes. So this question first.
Oh, no,
what?
just for the lady.
Yes, so the mask that we had in one of the pictures way back when, let's see if I can get there. That's just to keep the person rigidly still in the, oh, it was in this video, that's where it is, in the treatment position. So nobody wants to move while they're getting radiated, but we want them to move less than 0.5 millimeter. So that mask helps us achieve that.
That sounds better than cage.
It does. Yeah, I've never heard it called a cage before. That sounds terrible. But it does feel like a cage. It's very tight. We often will use Ativan, like a short-acting Valium, to help people tolerate it.
Any other questions? Yeah.
You know, when you are diagnosed with cancer, and then you go to the doctor, and they ask you, do you want surgery or do you want radiation? And you are completely, I mean, you're not an expert for one thing.
Yes.
And secondly, you are completely, you know what I'm saying? So what kind of protocol do you guys use to educate the patient in terms of all the differences and for them to make informed decisions?
Right. It takes a lot of time. It takes a lot of time. The reason for it is that all of these specialties are all trying to get better constantly. We're trying to make surgery better, radical prostatectomy more and more accurate for prostate cancer, and stereotactic radiosurgery more and more accurate for prostate cancer. So we're all getting better at it. And we're getting so that It is a choice because you're as likely to be cured by surgery as by radiation for most prostate cancers. So it has to be a choice. We have to leave it to the patient when the cure rates and the adverse effect rate is neck and neck. So you'd want to make that choice. And for some patients, it's really clear, I'm not going under the knife. Other patients, no way I'm having radiation. Then the other patients are tortured because they don't know what to do. And it is a problem. So I would say our prostate consults are often an hour and a half long, going through the pros and cons of all of these possibilities.
And then the last question, if you don't mind, could you elaborate on the shielding process a little more?
Right, the shielding is in the head of the radiation unit. So in this picture, you can see that the actual treatment beam comes out of the head of the machine. Sort of the rounded, I can't show you because my cursor isn't working, which makes me sad. But the top of the machine, I'll show the people in the room. Is it clear to you that's what I'm talking about? And the reason that that is so deep is because it's shielding. Okay, so the primary beam is coming down a really long tunnel of high, it's mostly titanium, zinc, lead, cadmium, a blend of different metals that will stop the beam. So we generate the X-ray and then we send it down this long tunnel. And what the tunnel does is it absorbs side scatter. So the beam that's coming out of the head of the machine is very forward directed. So the scatter to the rest of the body is already dramatically reduced. And then just before it exits the head of the machine, that's where that system of moving leaves is. And those leaves are actually about 8-10 centimeters deep. So the beams coming through here, those shields are sort of interdigitated and they move in concert with each other, but they're actually highly effective shields. So they have their beam stoppage is worthy. They reduce the exit of that beam to like 0.5% or something. Very effective shielding.
Wonderful. Thank you so much for the presentation and your time, Dr. Endicott, and for everyone that joined today.
People could email